Right, we'll get cracking. So good evening, everybody. I hear there's been a huge surge in people wanting to learn about scapular fractures, so that's great. But we'll kick off the first journal club of the year for BESS, and it's going to be hosted by the team from Royal London, who are going to educate us on scapular fractures. Um, Bit of housekeeping just before the session is being recorded, just so everybody's aware. The audience will be muted though, but any questions that you have, please put them on the Q&A on the Zoom at the bottom of the screen, and then the Royal London team are going to take question and answers out after the presentation of the three papers, and we'll go through as many of those as we can and answer them live. We should aim to be finished by 8, so we will be have a snappy finish. Um, this is the Royal London team that are kindly going to facilitate the session today. And I'll hand over to one of the fellows there, Mayor, who's going to kick us off with the first paper. Over to you, Mayor.
Well, good evening. My name is Mayur Naik. I'm one of the upper limb fellow at the Royal London Hospital. So I'm going to talk about the study conducted by Smid et al. From Sweden that was published in Journal of Shoulder and Elbow Surgery this year in February. The title of the study is Epidemiology, Treatment and Mortality of 3,973 Scapular Fractures from the Swedish Fracture Register. So scapula is an important bone in the shoulder girdle that functions as shoulder stabilizer and enables the shoulder to perform various complex movements. The traumatic presentation of shoulder can be varied, and its consequences can be relatively simple to very catastrophic. And that's why understanding of this fracture is very important so that we can make a systematic approach to this problem, and thus the need of national epidemiological data. This study utilizes Swedish Fracture Register, which has evolved from being a single center register with data collection on only 2 fractures types in 2011 to include all fracture types and reach 100% national coverage in 2021. This register is one of the 34 national fracture registries around the world. The aim of the study was to provide a comprehensive and an updated description of the fracture demographics, its classification, associated fracture, treatment, and mortality. The design of the study was a retrospective observational study, and it followed Strobe 2011 guidelines. It included adult patients over 18 years of age who were registered between March 2011 to June 2020, so over 10 years of time. The exclusion criteria were non-classified fractures, periprosthetic fractures, and pathological fractures. So all in all, it analyzed 4,128 patients, out of which 155 fractures were excluded, and thus there were 3,973 fractures in 3,930 patients. It was approved by the Swedish Ethical Review Authority, and it was conducted in accordance with the ethical principles of Helsinki Declaration, revised in 2013. The outcome variables were age and sex, injury mechanism, which was divided into falls from height, fall from the same level, unspecified falls, road traffic accident, stress fracture, and other causes. Fracture classification, for which it utilized simple classification, Euler-Woody classification, and Heidenpluck classification. Associated fracture, which were grouped based on their location, the treatment received, and the mortality. It largely used descriptive stats. The categorical variables were expressed as frequency and percentage. The continuous variables were represented by mean or median with standard deviation and range. Age distribution by sex was depicted by bar plot. Fracture occurrence was calculated on monthly and weekday variation. Concomitant fracture were assessed for fracture location in relation to the simplified and the Euler-Woody and Heidelberg classification. It was all done through a statistical computing software. Coming on to the demography of the study, the mean age was 58. The most common age around male was 50, and female, it was around 60 to 75. A notable finding of the study was that females younger than 50 years of age were rarely affected by this fracture, whereas in males it was distributed around all the age groups. There was no difference in the site affected. However, this study does not talk about the difference in the frequency between the genders. Coming on to the injury mechanism and the type of trauma. A very interesting finding of the study is that these fractures are relatively low energy, with fall from the same level being the most common mechanism. A previous study in 2011 reported that 90% of this fracture are caused because of the high energy trauma, in contrast to this study, which suggests only 22%. Males are 3 times more likely to be affected from this fracture from high energy trauma, whereas females are more commonly affected from low energy trauma. Coming into monthly and weekday variation, the annual variation displays most scapular fractures in winter and early summer. During the summertime, the possibility of the sport activity increases, augmenting the risk of sustaining more higher energy injuries. Men sustain more scapular fractures during the weekend, which is probably connected again to the high energy leisure activities, whereas women display an equal injury pattern over the week. Coming on to the fracture classification, so Smith et al. Classified their fractures into 12 types based on simplified classification, Euler-Woody classification, and Heidelberg classification. Fractures to the glenoid neck and the scapular body had the largest share of high energy caused fracture, and also the largest proportion of road traffic accident caused fracture. However, the same level of falls were the most common cause of glenoid fracture and the cause of most fracture to the glenoid rim and intra-articular fractures to the glenoid. Coming on to the associated fracture, so 1/5 of this fracture, scapular fracture, have associated fracture, most common fractures being clavicle and proximal humerus. It was seen that clavicle fracture are more commonly associated with the body fractures, whereas proximal humerus fracture are associated with intra-articular or rim fracture. 5% of this fracture, that means 1 in 20 fracture, had other fractures such as spine, pelvis, and lower extremity, and they were more commonly affected with scapular body fracture, which aligns with the fact that these are all high energy trauma and thus needs a high suspicion when we are treating these patients. Treatment. So of all the fractures, only 15% of these fractures were treated operatively. Non-operative treatment was adopted for rest 81% of fracture, with scapular body exclusively being treated non-op. This correlates again with the previous study done in Finland, where it showed that only 12% of the hospitalized patients needed operative treatment for scapular fractures. Coming on to the mortality. So the 30-day mortality rate was 0.8%, with highest incidence of fractures of the scapular body and highest overall mortality rate, again in the scapular body, which was about 5.3% and 8% after 1 year. Overall, the rate of mortality was about 4%. In all the type of fracture, the mortality increased over the 12 months of time. So suggesting the fact that these patients need to be followed up in our clinic. So most of the scapular fractures are low energy injuries. High energy injuries are overrepresented in glenoid neck and scapular body fracture, and these are seen frequently in men involved in road traffic accidents. Almost 1/5 of the patients have concomitant injury, and we need to keep that in our mind. The strength of the study was that it had a large sample size. The inclusion of 3,973 scapular fracture, it provides us with a robust data set, enhancing the statistical power and the generalizability of the findings. It utilizes the Swedish Fracture Register, which allows for detailed insights to the parameters measured in this study. This study employs established classification systems such as Euler-Rudy and Eidel classification. This facilitates a nuanced understanding of various fracture types and their respective epidemiological characteristics. And the analysis of the treatment modalities revealed that non-operative management was employed in 80% of the cases, and specific fracture patterns such as glenoid ream and intra-articular glenoid fracture needs surgical intervention. The limitation of the study is that this was an observational design, so it cannot establish causality between variables. This study acknowledges that Swedish Fracture Register had an approximate completeness of only 60% in 2020, which then again increased to 100% in 2021. This incomplete data may introduce selection bias and affect the representativeness of the data that the study has given us. This study focuses mainly on the epidemiological data, treatment approaches, and mortality, but does not provide any information on patient-reported outcomes or functional recovery post-treatment, which are crucial for us as surgeons to assess the effectiveness of management strategies. The reliance on the registry data may lead to misclassification or coding errors, which could also impact the accuracy of the data presented. And there is always a potential of reporting bias. For example, an arthroscopy surgeon might report less cases as compared to a trauma surgeon. Thank you.
Thanks, Maya. Good evening, everyone. My name is Daniel Benz. Thanks for the opportunity to present this review article on the management of extra-articular scapular fractures. So the paper aimed to, via a commentary, via a narrative review, to comment on the current evidence base that guides management of extra-articular scapular fractures, and then ultimately to provide a treatment algorithm that would help guide clinical practice. The paper was published in 2023 in the journal Clinics in Orthopedic Surgery, and the supervising author was Bassem El Hassan, who's a clinical and academic orthopedic surgeon based at Massachusetts General Hospital. So the fundamental flaw of this paper, and with all other review articles on the management of scapular fractures, whether they be a narrative review or a systematic review or any attempt at a meta-analysis, is that there's a true lack of any underlying robust evidence that can guide management, and the authors really do acknowledge this throughout the paper. In fact, a systematic review in 2018 found that there were no randomized control trials nor any prospective cohort trials to help guide management decision. And the evidence base that we do have is based on retrospective reviews of small cohorts, of small patient cohorts and case series. And these are almost always underpowered and have significant heterogeneity, particularly in terms of the classification systems used for extra-articular fractures, scapular fractures, but also on the outcome measures, making any direct comparisons very difficult. In fact, of the available evidence that we do have that directly compares operative versus non-operative management, only retrospective reviews of very small case series with limited numbers are available to us. I just thought I'd take a quick second to in consistency with that theme. This systematic review in 2018 is continuously referred to throughout the paper. I thought I'd just take a second to discuss this in a little bit more detail. So it essentially was a systematic review of all the literature up until February 2014. So the authors found, or were able to include one meta-analysis, two systematic reviews. There were no randomized control trials, and the remaining evidence were retrospective or prospective case series and one cohort study. The original aim of the paper was to perform a meta-analysis, but the available evidence that they did have were case series without randomization, without blinding, and this precluded any meaningful statistical evaluation of the evidence that we have. And with most systematic reviews that are based on poor evidence, the concluding comment was that a multi-center randomized trial was needed to provide more reliable data regarding indications for surgery. And then if we sort of take the next step and say, well, what's the evidence since February 2014? We have a cursory look at PubMed and search via the keyword scapular fracture and management as keywords in the title and abstract. We're presented with 22 results, and of which 10 are relevant. There's 5 systematic reviews, 4 reviews of other nature, including this paper that we're discussing today, and 2 case reports. So we can see even since that systematic review in 2018, there's been a real lack and deficiency of original research. So the authors of the paper elected to consider extra-articular fractures into 4 types, into acromion fractures, scapular neck fractures, scapular body, and inferior angle fractures. This is not aligned with any defined classification system, and the authors don't discuss why they are presenting it in this way, but they do acknowledge that 2 previous narrative reviews, an EFORT review in 2021 and another systematic review, also grouped the extra-articular fractures into these subheadings. These authors, though, did include inferior angle fractures of the scapula because from their perspective, the current evidence base suggested different management considerations for those injuries. The paper starts by briefly discussing the management principles. And the underlying principle is that for any extra-articular scapular fracture that has sufficient displacement to affect glenohumeral or scapulothoracic function, then that may well be a relative indication for fixation. Of course, keeping in mind other factors like the patients themselves, any associated injuries, and the skills of the surgeon. The skills and experience of the surgeon. They initially list a multitude of indications that have been published throughout the literature for extra-articular scapular fixation, but fail to rationalize those indications to begin with. The paper briefly discusses 3 additional considerations in the assessment and management of scapular fractures, and I just thought I'd take a moment to highlight these. So the first is fracture patterns that are prone to progressive deformity. They reference a 2010 paper in the Journal of Trauma, in which a retrospective review of 49 operatively treated scapular fractures were undertaken. The authors identified 8 of those that were initially managed non-operatively, but then underwent loss of position enough to warrant fixation at an average of about 11 days. And the top right diagram there is essentially a mapping of those fractures that did displace. And these essentially correlated with a Ader and Miller type 2C fracture of the inferior blade of the scapula. So perhaps keeping this fracture pattern in mind when we're following up our non-operative scapular body fractures. The second concept was that the 3D CT reconstruction measurement of glenopolar angle, which we'll talk about soon, is significantly influenced by the rotation of the scapula around the thorax. So with any internal or external rotation of the scapula on the thorax, the glenopolar angle will be significantly underestimated. And the authors suggested that a standardized AP reconstruction with 0 degrees of rotation should be the standard by which glenopolar angle is assessed. And finally, the third consideration that they briefly discuss relates to the concept of glenoid neck medialization as an indication for reduction and fixation. They referenced a paper by Scott Zuckerman and William Obransky that are based at Vanderbilt University, that suggested that true medialization of the glenoid in glenoid neck fractures with reference from the midline and compared to the uninjured upper limb was much less frequent than we thought, and suggested that caution should be undertaken when just evaluating the glenoid itself and measuring medialization. So the first group of fractures that the authors discussed are acromion fractures. So non-operative care can be implemented for non-displaced and minimally displaced fractures. The general consensus of the limited but available evidence is that displaced fractures and those that are associated with a disruption of the superior shoulder suspensory complex, constituting a so-called double disruption, are better managed operatively. Apart from acromial fractures resulting in a decrease in the subacromial space or associated with traumatic rotator cuff tears, measurements that actually define displacement are not outlined, nor are they outlined in the referenced paper by Hess in 2018. So the concept of the superior shoulder suspensory complex that was described by Goss in 1993, it's an osteoligamentous ring that creates a firm and stable relationship between the axial skeleton and the upper limb and acts as an anchor point for muscles. It's formed by the glenoid, the coracoid, the coracoclavicular ligaments, the distal clavicle, the acromioclavicular ligaments, and the acromion, and then the scapula, and finally the scapular spine to complete that ring. So unlike pelvic injuries, for example, you can have single disruptions of this ring as the force transmission can actually exit out intact coracoclavicular or acromioclavicular ligaments. But when there's a double disruption in this ring, whether that be bony or a complete rupture of the CC and AC ligaments, this portends to significant segment displacement, delayed and non-union, and eventual functional disability. And this concept helps rationalize the management of complex shoulder injuries. So the second group were scapular body fractures, and we know that the vast majority can be managed non-operatively. The operative indications that the authors present are non-isolated fractures that I think should be taken with a grain of salt, and also a number of parameters that we can look at on our imaging to infer whether an operation would be of benefit. So in terms of scapular body fractures being non-isolated, the authors reference this 2009 retrospective review of 22 scapular body fractures that were managed non-operatively. Essentially, this paper showed that isolated fractures, patients with isolated scapular body fractures showed eventual equivalent function as assessed by DASH and SST scores, with reference to the contralateral limb. So essentially they had function equivocal to the uninjured side once union had occurred. But when these scapular body fractures occurred in the context of multi-trauma, non-operative care resulted in poorer function. So the authors in this paper didn't suggest that multi-trauma should be an indication for surgery. However, the authors of this review include this as one of their indications, which I don't think is particularly appropriate. The remaining indications for scapular body fracture fixations based predominantly on expert opinion that's been verified to varying degrees in subsequent papers. A retrospective review of 22 operatively treated scapular body fractures that were published in 2010 utilized those remaining indications for fixation and showed a 95% satisfaction amongst their operative patients. So the third group is scapular neck fractures. So 83% of these can be managed non-operatively with an expected eventual constant score of 78 out of 100. Residual issues the authors highlight include stiffness, abduction dysfunction, and subacromial pain. The operative indications that they identify include a glenopolar angle less than 20 degrees. Andreas Dr. Imhoff from Munich in 2001 undertook a retrospective review of 19 scapular fractures and identified a poorer functional outcome in those patients that had a glenopolar angle of less than 20 degrees versus those that had a glenopolar angle above 20 degrees. So glenoid neck medialization and anterior angulation as an indication for surgical neck fractures is based on the premise that it results in a disruption of the biomechanics of the cuff and translates the normal compressive glenohumeral forces into shear forces across the glenohumeral joint, predisposing to instability and arthrosis. Glenoid neck medialization greater than 1 centimeter. A systematic review in 2018 included 3 studies evaluating this fracture pattern, and they found that there was a satisfactory result in 95% of patients that had medialization less than 1 centimeter, and only 16% satisfaction with medialization of greater than 1 centimeter. And all of those that underwent surgery had, in inverted commas, satisfactory results. The other concept of a fully unstable scapular neck fracture refers to the concept that the stability of a surgical neck fracture of the lateral glenoid component of that injury is influenced by the integrity of the ligaments that are attached to the coracoid, so the CC and the CA ligaments. So if these ligaments are intact, it prevents the pull of the muscles that attach to the coracoid, whereas if these ligaments are disrupted, there's an unrestrained deformation force on your glenoid component. This needs to be considered when planning operative versus non-operative care. And finally, body extension associated body extension has been shown to have poorer functional outcomes. The final group is inferior scapular angle fractures. These tend to be high energy patterns. Most can be managed non-operatively if they're non-displaced. And the author suggests that operative intervention for displaced or, in inverted commas, missed fractures should be undertaken. The paper, the narrative review references this systematic review in which included 17 case reports of only 22 patients. So again, not the most robust evidence base. So with non-operative management of inferior angular scapular fractures, there's a close to 90% failure if they are displaced, but an 83% success if they're non-displaced. And in terms of missed fractures, this review included 3 case studies of missed fractures, and only one of them described success with conservative management. So the authors of the paper that we're reviewing suggested that missed fractures should be an indication for surgery, but this is fraught with significant publication bias, and again needs to be considered again with a grain of salt. And the final group is pediatric scapular fractures. The literature is based on several case studies, really pediatric fractures that have got indications that we've previously discussed. There's no literature describing late developmental sequelae of scapular fractures, and there's no treatment algorithm that's offered. So the authors do present a treatment algorithm that we've already gone over, but for those interested can look further at the paper and have a look at this treatment algorithm. So the limitations are really based on the limited evidence that we have available to us. It's a narrative review. It's open to significant bias. There's no description of selection or inclusion criteria and no critical appraisal of the included literature. Thank you.
Thanks, Joe. So we've already heard from Daniel and Maya, and essentially there is a complete lack of prospective RCTs on scapular fractures. So in terms of critically appraising, it's very challenging to find papers that warrant it. So I'm going to present this paper by Peter Cole from Minnesota, which is an excellent paper in providing a narrative review of the operative techniques in the management of scapular fractures. And I'd strongly recommend anyone who has to treat them reads it. It's very helpful. So if you do the next slide, please. Yeah, this is the paper by Peter Cole, who's out of Minnesota and has published highly in scapular fractures. Next slide, please. Great. So scapula is a flat and triangular bone with 18 muscles crossing it, originating or inserting on its borders. And this provides cortical areas of strong bone with excellent biology for fracture healing. Again, if you go on to the next slide. And in Cole's review, he discusses the neurovascular, which is affected by a posterior approach to the scapula. And as you can see on the left side, you've got the scapular nerve, which runs laterally in the posterior cervical triangle, exiting through the pubic notch and along the coursing along the floor of the supraspinous fossa towards the glenoid rim. And then it enters the infraspinous fossa via the spinoglenoid notch. On the right side, we can see the ascending branch of the circumflex scapular artery, which is the terminal branch of the subscapular artery and runs along the lateral border of the scapula. And in the posterior approach, which is the most common approach for fixing scapulas, these are our 2 primary concerns. If you go on the next slide, please. And this paper by Armitage outlines the 478 triangle, which is the danger zone between the spinoglenoid notch, the suprascapular bundle, and the circumflex scapular artery. And so any metalwork in this area, it has to be done with a degree of caution. Next slide, please. Sorry. And Cole also again outlines, provides an overview of this paper by Armitage, which maps scapular fractures. And it demonstrates that 68% of fractures, actually operative fractures, involve the inferior glenoid. We can see that in the top left picture. Only 17% end up having an intra-articular component. And 22% involve the spinoglenoid notch. And this is basically a mapping of all of the different fracture configurations. And that's been discussed earlier by Daniel. If you do the next slide, please. So the paper is particularly helpful for helping you choose your approach. And the posterior approach is favored almost exclusively, except in anterior glenoid fractures, isolated fractures involving the coracoid or superior glenon fractures. Just go on the next slide. And this is the setup that Peter Cole advises. So the patient is in lateral decubitus. You can see that there's a bone foam on the opposite side, which allows the entire extremity to be prepped and draped. And a really useful take home for me from this was that by prepping and draping the entirety of the ipsilateral extremity, this allows you to maneuver the arm, which is crucial for actually helping you reduce the fracture, which is the hardest bit of the scapular fracture fixation. If you will also note in this image, the patient slumps slightly forward, and that again improves visualization of the scapula. Next slide, please. This is the instrumentation recommended by Cole. Most of it would be on a typical orthopedic tray, but things I thought were interesting, he particularly advises using the shoulder hook, but also the Cobb elevator, which I'll come to later, and both medium, large Hohmann and Diva retractors, which can be quite tricky to find. Next slide, please. So the paper outlines the 3 different approaches to the scapula. As Daniel's discussed previously, it doesn't provide any rational evidence for why which approach should be chosen, but it is purely descriptive. He advocates the extensile Judet approach for any delayed surgery. Due to the excellent vascular supply around the scapula, it's able to form callus within days. So for anything longer than 2 weeks, he would advocate the extensile Judet approach. Modified Judet approach for acute fractures where you don't need to see the posterior scapula, and then minimally invasive approach where fracture patterns have simple double exit points. Next slide, please. So for the extensile Judet approach, there's an angled incision 1 centimeter inferior to the lateral scapular spine, which is carried medially to the vertebral body of the scapula, then curved inferiorly down to the inferior pole with full thickness flaps through the fascia. And then if we move on to the next slide, and just orienting yourself, so you're looking at the patient rolled over to the side. So the horizontal on the bottom of the screen is the vertebral body, and the scapular spine is running vertically. And so continuing that approach, he advises sharp dissection of the posterior deltoid and infraspinatus from the origin on the scapular spine, and then the use of a Cobb to sort of scrape all of this muscle back to create a muscular flap en masse. Then blunt Hohmann or Diva over the lateral border to facilitate visualization. And the images are, really helpful in these in sort of helping bring to life what's quite a complex thing to get your head around when starting out. Yeah, next slide, please. The modified Judet approach, first coined by Bremski in 2004, avoids elevation of the entirety of the posterior musculature by going between teres minor and infraspinatus, and you can see that here. Yeah, next slide, please. And so this is again from Cole, who demonstrates how you can elevate, but the only disadvantage is you wouldn't have quite the same level of view, particularly if there was extensive callus formation as you would get with the full Judet approach. And again, the next slide, please. This is the minimally invasive approach which he outlines. And so you've got, this is only for dual incisions on where you've got simple fracture patterns exiting. And so if you look at the lateral incision, it's 5 centimeter incision from the glenoid neck running down the lateral edge of the scapular body. He then advises dissecting through to the fascia, the inferior border of the deltoid, opening the subdeltoid space, and then you can go through the interval between infraspinatus and teres minor in that plane. Whereas the medial incision on the right is centered on the fracture exit point, dissection down to bone, and the musculature elevated to visualize the point. But as you can see, comparative to the approaches that Cole has gone through previously, This does give you very limited visualization of the scapula, so can only be used in relatively simple fractures. And again, the next slide, please. And where this paper, and I'm not critically appraising it in the traditional format, because as we've discussed, there is simply no prospective scapular studies which you can use. But where the paper is particularly excellent is providing 5 pearls for reduction techniques to help with management of the fracture. And so first of all, he advises putting a Schanz pin in the glenoid neck. And this is a joystick for the proximal fragment. So with the weight of the arm and all of the musculature attached, the hardest thing with the scapular fractures is trying to get control to reduce each fragment onto each other. And by putting that Schanz pin, as you can see there, into the neck, this allows for derotation and translation of the neck to align with your distal fragment. So that's pearl number 1 he describes in the paper. If we go on to the next slide. Number 2, the shoulder hook, which isn't on every tray, can be put into a pilot drill hole in the distal fragment and then used to help control that distal fragment. So if you've got your Schanz pin in the proximal fragment and your shoulder hook in the distal fragment, this allows you to get control of both aspects of the fracture. And the next slide, please. And if you can see here, he's done drill holes in both and then used the tenaculum through the drill holes to help compress across that fracture point. Next slide. For fractures that are over 2 weeks old, this image is meant to demonstrate a huge amount of callus around that area. And so he advocates using a laminar spreader to open up the proximal distal fragments so you can then remove the callus and enable your reduction. And the 5th point, sorry, on the next slide. And I thought this was really helpful. So in comminution, it's extremely hard to control length. And so he says using a mini X-Fix 4mm Schanz pins, you can maintain length and alignment while you apply definitive fixation. And so if anyone who's starting out and is interested in managing scapular fractures, I think these 5 points are extremely helpful and not something I'd come across elsewhere. So from a purely descriptive point of view, extremely helpful paper in that regard. If you go on to the next slide. Yep, so this is the link to the paper. I think it's free open access. It is a purely narrative review. I didn't want to repeat Daniel's criticisms of all of these scapular papers, but as with excellent pictures and excellent explanations, I would advise anyone who has any scapular fractures coming up to have a look at it. Great. Parag, shall we move to any questions at all?
Yeah, so there's currently no questions in the Q&A. So just to the attendees, do please put any questions or discussion points. I saw a couple of people raise hands, but please do jot down the questions at the bottom in the Q&A and then we'll field them to the panel. But Rory, I think you had some cases, right, that we could discuss.
Parag, while we are opening up some cases, can I ask a question? Sorry, I'm Amol Tambe. I'm the BEST EdCom chair. From the first presenter, Mayur, thanks for your presentation and as well the rest of the team. In your presentation, you talked about, I think towards the end of the slides, that mortality in scapular body fractures was the greatest. And I understand from your presentation also that this is the group which is also treated non-operatively. So what is causing this higher mortality in the body fractures? Was there any clarity in the papers you looked at about what correlates with
yes.
Why?
So the most
yeah.
So the most common cause of the most common associated trauma with scapular body and neck fracture is high energy velocity and road traffic accidents. So the main thing is that these patients, they suffer multiple injuries. Even with the rest of the papers and the studies, it has been shown that these patients have IESS to a higher level. that causes this problem.
Yes.
And it was again repeated in the same paper.
Good, thank you. Yeah, I think it's an important point because it is true that with body fractures and the energy that goes through, chest injury is I think a big issue with this group of fractures, and of course with the nerves and blood vessels in the vicinity again. Good, thanks.
Question, I guess, for Nick, who's probably dealt with a few than the rest of us, but how are you immobilizing the patients afterwards? Do you just keep them in a polysling, or do you put them in a quadrant brace or a shoulder spiker, and for how long are you kind of restricting them?
Yeah, hi guys. Thanks for having us this evening. Normally just a polysling, but I think especially when Rory starts delving into some of the cases, one of the big indications for intervening with scapular fractures is the polytraumatized patient who has multiple limb injuries on the same side. So that normally kind of determines what you do with them postoperatively. But in isolated scapular fractures, a polysling is more than good enough.
If there are any AHPs who are watching you, I'd be interested to know what your approach is to actually the rehab of scapular fractures. From speaking to people, I'm currently in Australia, North Shore. It's just there is no set guidance for scapular fractures. They follow the same as if for a proximal humeral fracture. So I'd be interested to know if anyone actually watching this. I know we've got a few HPs watching. How would they rehab a complex scapular fracture? Because I couldn't find anything myself online.
It's quite funny. On the back of that, Rory, we were all chatting recently about trying to get an AHP on here. And bearing in mind, we're a massive trauma centre and we see a hell of a lot of scapular fractures compared to other units. Most of our physios were a little bit apprehensive about coming on because they don't really see enough. It's not as though you can just look up how to rehab a scapular fracture. And again, so many of them are in these polytraumatized patients with loads of issues going on. So it would be great for us if there's anybody out there who's seen a bit more of this than the average physio and so on, who can give us some pearls. Silence says it all, doesn't it?
Yeah.
No takers. Nick, from your experience with these fractures in the polytraumatized group, do you see problems like heterotropic ossification around these fractures, especially some of them who get delayed because you can't address them early? Does that become an issue later? Not that I can remember seeing this problem, but your experience, please.
Yeah, that's a really good question. And actually, one of the interesting things about scapular fractures is that so many of them get lost to follow-up because often they're jumpers or out of region. So we've just recently published a big series of R1s and looking at outcomes, operative versus non-operative. And actually, the number of patients we were actually able to track down and follow up was tiny. It was a fraction of the number of scapular fractures we see. So it's really difficult to form good opinions on these patients. I don't think the body fractures, hypertrophic bone formation is an issue. I think the intra-articular ones tend to be a problem. And even down the line, when there is an issue, certainly the ones that I've had more to deal with, we tend to just leave them alone, and then if necessary, come back and do a reverse, even in the young patients. And there seems to be much better outcomes in trying to do these big judo approaches where you're taking down callus and so on and so forth. But yeah, it's really hard. I think there's very few people in the world who have enough experience with enough of these patients to be noticing these types of patterns, I think, anyway.
Sure, thanks.
Great. So we have a few cases of next just to bring this to life. So first patient. So this is a 30-year-old man, high energy injury. I believe he fell. And this is the fracture configuration, as you can see here. Anyone in the audience feeling brave enough to describe what approach they would consider doing, or whether it even needs fixing based on the evidence? You'd have to be pretty brave, to be fair. Okay, well, if we go on to the next slide. Nick, I don't know if you want to take through what approach you did in order to fix this one.
Yeah, so it's quite interesting hearing your talk, Rory, because in theory you could do this one with a direct lateral approach, or through isolated windows. But I think it's really difficult. And you look at the anatomy and you think it's going to be relatively easy, but then actually you get in there and you realize the reduction maneuvers are really tough. I think that's the hardest thing about operating scapulars. To get the view of the glenoid, which is what you're trying to reduce, and get all the muscles out of the way, it's tough. So to be perfectly honest with you, most of mine get full-on judo approaches. It just gives you much better exposure. You can see what's going on. You can protect the neurovascular bonds more easily. So I'm pretty sure if it was one of mine, it would have got a judo.
And the next one. Yeah, so this is a patient, I believe, 18-year-old who cycled into the back of a car at high speed. If you go on to the next slide, I think we've got some CTs there, Joe. So severely comminuted. Again, intra-articular, and onto the next slide. And that is the aftermath. Again, I guess, Nick, you must have done a full extensile judo for this one.
Yeah, so we were talking about this guy earlier. This poor guy was training because he was on the cusp of getting into one of the Sky cycling teams, and he was just going for it in his time trial and had his head down, and then went straight into the back of a garbage truck and ended up like this. The poor guy. So yeah, I mean, this gets a full judo approach. As far as I know, the only decent plates on the market are these Acumed plates. The boomerang plate, I think it's one of those plates that you really want to use, but I'm not sure how useful they actually are. Whereas the infraremedial one's much, that's kind of the bread and butter because that's what's going to reduce it and hold your glenoid in the right position. But actually, the periarticular component of this, which is where the money is for scapular fractures, is probably where the hardware is the hardest to come across. So this is just a simple third tubular. But going into these, I think it's really useful to have a handset. So we've got the Synthes hand stuff on the shelf, so your little T-plates. I think they're really useful to try and get all those articular fragments back into place. But again, as Rory said, this got a big old full judo approach, and from memory, I think this guy did pretty good with his rotation afterwards. But as a cyclist, having a bit of ER weakness wasn't the end of the world for him.
And I think these plates are actually designed by Peter Cole, who's the first author from my presentation. The last one, please, Joe. Yeah, so I mean, again, super high energy. I think this was an 18-year-old traveling another cyclist. Complete comminution. I think we've got a really good CT. Next one. Yeah. And just on to the next one after that. And again, sorry, I put a few. And so that's the construct. And again, it would have been for an extensile judo. And I think one thing that's worth saying for these, especially with patients who come in critically unwell, is quite hard to get to them quickly. So I'd imagine quite often there's a lot of callus there when the patient's able to actually go to theatre because they need other things managed first, especially the high energy scapular fractures. Do you want to speak on any tips that you'd use to fix this one, Nick?
Yeah, to be honest, I think this was I can't remember if this was one of mine or Olivier's, but one of the problems when you've got this one, so if you go back to the CT, if it's the case I'm thinking of, the half the glenoid has escaped anteriorly. Is it this one? So just say sometimes you get the smashed glenoids and you get some fragments being popped out anteriorly. So what you occasionally have to do is think about doing dual approaches. So you go in the back, get everything reduced, hold it in place, but then you still have to go into the front of the shoulder and try and reduce the fragments on separately. And in those cases, simple coracoid osteotomies, getting the conjoint tendon out of the way, giving you that access to the front is nice. If you really want to push the bed up, you can have a tackle at going after those anterior fragments which fly off arthroscopically. But after muddling around the back for a few hours, it's probably not the most exciting thing to do. So for those cases, you've got to have it in mind how you're going to set them up, whether you're going to allow them to go into kind of a sloppy lateral where you can access the front, and then obviously it's not a position most of us are used to, so it can throw you off a little bit. I can't think of anything else for this case.
So I mean, in conclusion, anyone who's interested in any research, there's an absolute dearth of research and prospective research in scapular fractures and also the rehab of it. So hopefully we can motivate someone to actually do some research in this field because it's crying out for it.
We've had a couple of comments and one question. So Sarah Jones, who I assume is one of our AHP attendees, has said she worked in a major trauma centre for a long time and would agree with the previous comments that physios don't see many scapular fractures, and it is often in the polytrauma setting, and the rehab is generally a functional rehab. And the scapula may not be the biggest concern for the patient. So she would treat the imbalance and the stiffness. So thank you, Sarah, for that. We've got a question from Mike Goldring, who's asking, do you have an order to fixing the fragments?
Not really. Just kind of figure it out when you get in there. As I said, I certainly haven't done enough to figure out orders for fixing fragments, and I don't think there's many people around the world who probably have. So, yeah, not particularly.
Fair enough. Got to deal with what's in front. There's no algorithm for it, I imagine. And then one final question. Sorry, a couple of questions from George, who's asked, doesn't a coracoid osteotomy destabilize the glenoid neck further?
Yeah, so make sure to fix it afterwards, I suppose. If you need to get to the front and you need to see medial enough, it's the only real way. Otherwise, you're muddling around fighting the conjoint tendon the whole time. As long as you fix it off, and I'm sure you've all been and done them before. You just prefix it with a cannulated screw, and then putting it back on is dead easy afterwards. Whereas if you're trying to fix back an osteotomy, which you haven't pre-drilled or pre-screwed, it's an absolute nightmare.
Yeah. And then he's just asked quickly whether a dry scope would help as well.
I haven't thought that far. Yeah. Possibly, but it's one of those situations where if you're gonna scope it and do it, you might as well do it properly. I fixed plenty of glenoid fractures, kind of big old chunks arthroscopically, but I haven't had the effort. Well, it's probably tall order to do a full old Jude and then sit the patient up and do an arthroscopic fixation of bits from the front. But yeah, it's a good idea.
Great, thank you. Well, I'd like to thank the Royal London team who've taken their time this evening to present. Mayor, Daniel, Nick and Rory, thank you so much for a very interesting paper discussion. Certificates will be issued to the attendees who have signed into this evening over the next week or two. The next Journal Club is due on May the 15th, and it's going to be hosted by the Oswestry team, who are going to present on some elective elbow topics. So I hope everyone signs up. There's a QR code here that people can quickly scan now or go to the best website later on. But thank you all for joining, and hopefully see you at the next Journal Club.